We're now recording. So hello, everyone. I'm super excited to have you all in this virtual space. We can't be in person still, but I'm holding out hope. One day we'll be in the same room as everyone again. But I want to welcome everybody to Med Talk, which is our diversity series with Pre-Health Advising. And I'm super grateful to the Department of History for co-sponsoring. And we have two of their fantastic professors that are going to be our guest speakers. If you are wondering, we actually had a diversity series last semester called Mocs Move Forward, but it was very similar to Mock Forward. So we had to change the name. So we went with Med Talk, which Med stands for Mocs Explore Diversity. So welcome. So I'm Teresa Blackman. I think most of you know who I am, but for those of you out in the virtual world, I'm Teresa Blackman. I'm the Pre-Health Professions Advisor, and I would like to introduce our lovely guest speakers, Dr. Kuby and Dr. Julia Cummiskey. So Will is an associate professor and associate head, right? Yeah. I said it virtually, so it's a thing now, of the history department here at UTC. He studies 19th and 20th century US history with research and teaching focuses in the history of marriage and family, the history of sexuality, cultural history, legal history, African-American history, and queer history. So he was recently appointed executive director of the Committee on Lesbian, Gay, Bisexual, and Transgender History, which is affiliated society with the American Historical Association, which is very cool, and is currently working on a new book, tentatively titled Heterosexual Education, Youth Pageantry, and the Molding of Straight Culture. So whenever that comes out, let us know. We'll buy it. Give it a good read.
If you're around in a decade, I'll be ready to peddle it off to you.
And then we have the fantastic Dr. Julia Cummiskey, who's a very dear friend of mine, and I keep monopolizing her time by asking her to speak at all these things. So I'm very grateful for her. And she's also an assistant professor at UTC in the history department, and her focus is on history of international public health. So that's why I monopolize her all the time. And medical research in Africa. She's interested in the interplay between social, political, and scientific forces in the formulation and implementation of public health policy in Africa in the colonial and post-colonial periods. And she's just fantastic in general. So
you're making me.
So with that, I am going to turn it over to, I think, Will, you took dibs first. Is going to bring us into our first topic, which is milestones in the LGBTQ plus healthcare history.
Well, great. Thank you, Teresa, and thanks to everyone for being here. And please jump in and let me know if my internet goes out. It seems pretty good for today, but this room is the room I prefer to present from, but it's always a little bit patchy, so just keep me posted. I'm happy to move. So this is a huge topic, and it lends itself to so many different conversations. And I just wanted to, therefore, give two big examples, or I should say actually one small example and one big example that are separated by about 75 years, just as ways to think about the interplay between LGBTQ plus issues, homophobia, transphobia, and public health concerns. This first example is a very small example from the early 20th century in terms of people's knowledge about it, the scale on which it took place. The second is a very big example from the late 20th century. Spoiler alert, I'll be talking about AIDS and the AIDS epidemic. And I'm going to try to connect the two examples in some ways, but I'm not going to overstate that connection. I mean, mostly, I think these are both interesting and important ways to talk about histories of public health and medicine from an LGBTQ vantage point, and I just wanted to share them. And I have a few images, so let me share my screen with you. Hang on. Let me just, I didn't do this quite right. Okay, there we are. Okay, so I want to start with this story of Ralph Corwinio, who was a resident of Milwaukee, Wisconsin in the early 20th century. Ralph Corwinio was an individual who we would refer to today as a transgender man. He was also biracial. Some accounts refer to him as Native American. Other accounts mentioned that one of his parents was African American and the other was white. So I'm not totally certain on racial identity, but I think it's important that he was non-white. He lived into early adulthood as Cora Anderson, initially identifying as a woman and training to be a nurse in Chicago. And while doing this, Anderson met a young woman named Marie White, and they became friends. And the two nurses in training, kind of their friendship was established kind of on the grounds of commiseration. They commiserated over their financial challenges, and also over just the indignities they suffered, the insults, the sexual harassment, the advances that they faced as nurses in training from male doctors. And in response to these indignities, they devised a plan to create their own alternative family structure. And from this point forward, Anderson took on the name and identity of Ralph Carwinio and adopted thoroughly a new male identity. And this was not just through dress and demeanor, but it was also by assuming within this household that they formed masculine husband role to Marie White's wife. Carwinio took on the job of hotel bellboy, while his wife, Marie White, took on the role of homemaker. And Carwinio later said to the press, this is a quote, "In a short time, I thought of myself as a man, and it never entered my mind that I was any different than the men about me with whom I laughed, joked, worked, and played my part," end quote. So I think that this speaks to what we would see as Carwinio's transgender identity. His initial transition may have taken place, at least on the surface, as a strategic way to escape economic strain and sexual harassment. But it seems clear that Carwinio's transition went much deeper than being just a strategy for forging an easier life. Recently, historians have taken to pretty unambiguously referring to Carwinio as transgender, even though that term wasn't in use in the early 1900s. One of the reasons that we know Carwinio identified as male is that when his relationship with Marie White came to an end, he continued to live as a man, eventually marrying another woman, Dorothy Klonowski, in 1913. And it seems that Klonowski did not know that Carwinio was trans when the couple married, and neither did the Justice of the Peace in Milwaukee, Wisconsin, who married them. Okay. There's a reason, I think, that this is significant and relevant to our discussion of LGBTQ plus health and medical issues today, and here's why. 1913 was the year that the state of Wisconsin started to require medical certificates for grooms who wanted to get married. Potential grooms needed to get a doctor's examination and then have a physician sign an affidavit saying that they were free of syphilis. In Wisconsin, it was syphilis. In other places, there were other medical policies. This is all a product of the eugenics movement, a highly repressive effort to place restrictions on who could get married and procreate in the name of upholding public health. And Ralph Carwinio underwent his doctor's examination and passed, which allowed for the legal marriage between two people with female anatomy in the year 1913. And I say this with some hesitation. I want to emphasize that I want folks to see Ralph Carwinio as a man. It was his identity. And in that sense, we would consider this to have been a heterosexual marriage. But I also do think it's important to recognize that in 1913, this would have been considered, once people learned Carwinio's history, and was considered once people learned Carwinio's history, a same-sex marriage that was clearly in opposition to law and convention in the context of 1913. So why am I telling this story today within this context of our conversation? I think it's an example of the complicated relationship between debates over gender and sexual identity and health issues in the early 20th century. We could draw any number of conclusions from this example, but one thing I see here is that in this case, anxieties over public health seem to have trumped anxieties about sexual and gender identity and behavior. This is not to say that there weren't alarmed reactions to Carwinio's story, and I think it's also worth repeating that I view eugenics as a scary and repressive form of public health policy. So the point isn't to say just like our bold efforts to do good trumped everything else. But all that said, it's still interesting to me that when queer relations became a part of public health discourse here in 1913, they don't seem to have had many long-term consequences for public conversations about health policy. And perhaps, and this is just kind of thinking out loud, but one of the reasons for this might be that the word homosexual was not a widely recognized social category at this point in time, and transgender and transsexual were not in use at all. And perhaps that's part of the reason that stories like this didn't seem to leave a long-term impression. Possibly language can play an important role here. And because since also in the 1910s, there were not long legacies of homophobia and transphobia, at least explicitly informing the public response to the eugenics movement. Okay, so that's the end. We're going to jump forward 70 plus years now to the end of, to the early years of the AIDS epidemic. And this is a totally different story. And it's in many ways a much bigger one, but it's an example where, kind of counter to the Corwinio case, we do see many examples of anxiety over same-sex sexuality overpowering the commitment to halting a public health crisis. So the basic, probably for many of you familiar narrative in many ways is that in 1981, doctors began encountering this puzzling new medical phenomenon in which young gay men were dying suddenly from opportunistic infections such as pneumonia and cancer caused by mysterious viral disease that damaged the body's immune system. Researchers at the Centers for Disease Control called the new disease acquired immune deficiency syndrome, or AIDS, and identified the means of transmission as the exchange of bodily fluids. Because the majority of early AIDS patients were gay men who required HIV through sexual contact, many Americans perceived AIDS as a gay disease, even though other victims became infected through IV drug use, blood transfusions, heterosexual intercourse, or birth from AIDS-carrying mothers. And in so many situations, people were coming down with symptoms and dying very soon after. So I think it's important just emphasizing just this totally terrifying nature of this historical moment. The emergence of the disease launched an impressive amount of organization and political involvement within queer communities, particularly within major cities. And it's important to emphasize, and I'll give a couple of examples of this at the very end, but it's important to emphasize that it fell on queer-led organizations in many ways to try to save themselves because of the climate of fear and homophobia that prevented many others from taking action. So this image here is an example of protest from the Gay Men's Health Crisis, or GMHC, which was founded in 1982 and grounded in an effort to spread information about the epidemic. GMHC, I'll talk more about what they did later on, but another organization was ACT UP, the AIDS Coalition to Unleash Power, an organization formed in New York in 1987, devoted to political action in fighting AIDS. Early ACT UP protests were direct responses to government inactivity and to many politicians' unwillingness to push for increased funding for AIDS research and efforts to speed up clinical trials for potentially life-saving medications. And I just to emphasize that the very famous slogan, "Silence equals death," part and parcel of the ACT UP, message and mission. Basically, ACT UP and organizations like it were protesting the general lack of concern being displayed from people in power toward the queer communities most affected by this epidemic. I mentioned a lack of concern from people in power, and perhaps most significantly, Ronald Reagan is the person we should be talking about, because Reagan, the president, was not comfortable dealing with the epidemic, in part because a very significant source of his support came from the religious right and the moral majority, a political action group founded by the Reverend Jerry Falwell, who used AIDS as a tool through which to spread hate, fear, and discrimination against gay men. Falwell was famously quoted as saying at one point, "AIDS is the wrath of God upon homosexuals." Reagan also, Falwell was one example. Reagan's communications director, Pat Buchanan, who had a platform for a very long time after this, was quoted as saying, "AIDS is nature's revenge on gay men." Basically, it seems that Reagan felt he couldn't alienate these supporters, and he had to play to the anti-gay prejudices of his base. This is, I'll stop myself from saying anything else, but basically largely ignored the epidemic and chose silence over action. So when we think about ACT UP members stating their slogan, silence equals death, they were in many ways talking about the president, who was choosing to stay silent on the issue of AIDS that was devastating communities around the nation and the world. You can see some other characters who are being called out here: Jesse Helms, Vice President George H.W. Bush, Phyllis Schlafly. I mean, the list goes on. So as the 1980s wore on, with each passing month, death and suffering from AIDS increased at a frightening rate. And scientists, researchers, healthcare professionals at every level spoke of the need for funding. And the argument is we need to raise money in order to be able to save lives. But the response from the Reagan administration continued to be indifference, apparently, and a general unwillingness to address AIDS publicly. In the famous anecdote, I guess you could call it, or the trivia point, is that Reagan did not publicly say the word AIDS until the year 1985, which was 4 years after the epidemic had begun ravaging the nation. By the time Reagan left office, the CDC had confirmed 82,764 AIDS cases and 46,134 deaths. So I think that this is, of course, an important story, and I should say this is in the United States, this is an important story about government inaction in the face of a public health crisis that was in many ways driven by anti-queer sentiment. And I also just want to again emphasize this point I was making earlier, that due to this inadequate public response, so much caregiving took place on a small scale community level, emanating from charitable organizations and nonprofits, from friends and families. And we should see this as, you know, a great form of activism, a massive, major political development, and yet it's also an outgrowth of this totally inadequate response from on high. So this is an image of GMHC's Buddy program, which was established to basically create people who were able to come visit people who lived alone often with AIDS, to provide some basic needs for them, to provide companionship and a sense of not being alone in spite of the messages that were being communicated to them from many other, you know, the outside world in many regards. And this is a painting that I love. I saw it in an exhibit at the Museum of the City of New York a few years ago called AIDS at Home. And it was a wonderful exhibit intended to show the ways in which intimate at-home caregiving became one of the most vital components of AIDS care in the face of this broader political and cultural silence. So I just think that this is, it's a beautiful painting, but it's also, I think, a powerful painting in talking about that public reaction or non-reaction. So again, these two examples I've been talking about have almost nothing in common, but I still think it's useful to use these two very different narratives as ways to consider how homophobia and transphobia have historically factored or not factored into public health conversations. And I'll leave it at that. And I will unshare my screen.
Thank you so much. And I think, Julia, you are up to share your thoughts with us.
Right, so I have a much less organized presentation than Professor Kuby, for which I apologize in advance, but I just thought I would start by sort of sharing some thoughts on the historiography of LGBTQ plus people in the history of medicine, and where there have been sort of developments and where I think there's still a lot of room for more scholarship, a lot of things that we don't fully understand. And so in the history of medicine and the history of public health, which are really my areas. And the first thing that I was thinking about is, I think part of what's important to think about when we think about medicine and LGBTQ plus people and the history is that so much of the history of medicine has been an evolution in ideas about what constitutes normal and what constitutes abnormal. And sexuality has been a big part of that, right? And so for most of modern medicine's history, homosexuality was formally defined as a pathology, right? As something defined as a deviation from the normal and from the healthy, which obviously made it really hard for people who were not cis straight people to get medical care that was sensitive to their needs and that wasn't trying to fix something that they didn't necessarily understand to be a problem with themselves. Just to be clear, so the main quote unquote Bible of mental health is what's called the DSM, the Diagnostic and Statistical Manual. And I say it's the Bible of mental health. It has its own history, which I could talk about another time. The history of the DSM is closely linked to the history of not just health, but health insurance. But basically it codifies the diagnoses that mental health providers use when they're treating people that they treat for mental illness. And homosexuality was a diagnosis in the DSM until 1973 when it was removed from DSM-3. And so I think it's important to understand that, if we're talking about LGBTQ plus people seeking healthcare, in some ways they had to navigate the fact that what their health concerns were not the things that healthcare providers necessarily understood them to be struggling with. Which leads us to another challenge with the historiography, which is as a result of laws that made homosexuality illegal for a long time in US history and for even longer in many other parts of the globe, people seeking healthcare would not disclose their sexuality to physicians. And so it is a challenge sometimes going into the historical record and trying to understand the impact of sexuality on interactions with the medical care community or the public health community, because people were not out. People were not out to their medical providers. They were not out to their families. They were not out to their communities. And so I was thinking about preparing this talk compared to the one that I did in the series on race and medicine. And in some ways, this has been a different challenge for historians, I think, to understand, because the categories have changed so rapidly in this time, and the language used to describe people's identity has changed really rapidly. And historians always struggle a little bit when the terms that we use to describe something don't mean the same thing period after period. So I'm going to issue that as a caveat. But I think, more recently, where a lot of us have seen this play out in real time is in the debate about transgender identity and the role of the medical profession in either treating what is understood to be a problem, or helping people find care and find care that affirms their true gender identity. And this has played out on a number of levels. There's still big debates, but one thing I was thinking about is, on the one hand, I think it was a real victory when homosexuality was removed from DSM as a diagnostic category. And yet in many ways, transgender people's ability to access, for example, gender confirmation surgery relies on them getting a diagnosis of a pathology, right? In order to access care, in many cases, you have to have a doctor's diagnosis of, what's the name? Gender dysmorphia, I think, is the formal category. And so in a way, the medical care system, by imposing that diagnosis, sometimes that is in fact a route to better care for people that identify as transgender. But it does also mean that the medical community is still then complicit in othering, in pathologizing something that isn't necessarily experienced as a pathology. And so it's really complicated. I would add to that, there's also an interesting history in intersexuality. And what you can see as you look at the history of doctors dealing with intersexuality is that, in fact, it tells us very little about intersexuality and quite a lot about what doctors think masculinity is, because it turns out in period after period, when a child is born intersex, that is to say that their genitalia is indeterminate, it does not fully match the forms that are associated with either male sexual identity or female sexual identity. There's a number of different things, and there's still debate within the medical community about what the best practices are. So sometimes it'll be chromosomal testing, but that's not always actually determinate. And a study a few years ago found that the most consistent predictor of whether a doctor would assign male or female identity to the baby was the size of what would be their penis. And basically the question of, would they have a big enough penis if they were a boy? And if not, then they were decided they would be a girl. So basically better to be a girl than to be a boy with a too small penis. That's the best predictor of what they do in those situations. Now, of course, that's setting aside the fact that determination is expected to be made at all, which is equally problematic, right? That's a decision that a doctor is making, sometimes in consultation with parents, sometimes not. And one of the things that I think it's important to keep in mind as we think about the history of sexuality in medicine is it has evolved partly in parallel with the patients' rights movement. And this is really closely linked to what Dr. Kuby was talking about with GMHC and ACT UP. It predates some of that to some extent, but it picked up a lot of momentum. And so if you look at, say, the 1930s, the 40s, and the 50s, doctors generally had a very paternalistic relationship with patients. Patients were not expected to have a significant role in their course of treatment, determination, decisions. In the longer history of medicine, that was actually an aberration. For most of history, patients have wielded a lot of power in relationships with doctors because they basically existed in a medical marketplace. And if you didn't like what your doctor was doing, you found another doctor who would do what you wanted. But with increasing regulation in the United States and Europe, doctors came to be pretty powerful in that relationship in the 40s and the 50s into the 60s. And it wasn't until these big movements on behalf of patients' rights and patients' autonomy really got going, partly driven by the feminist movement in the 1970s, the publication of things like Our Bodies, Ourselves, and then I think really accelerated with the sense of urgency around the need for AIDS patients to be better served by the medical system, that this happened. And so you get more of a less acceptance of doctors' sort of godlike ability to make decisions about things like sexuality and gender identity. So I'm throwing out a lot of topics here, and I think I'm going to hand it off to Q&A pretty soon, and I can elaborate on any of these things. As I said, this is not a particularly well-organized talk, but I also wanted to point out that much as I pointed out in that talk on race and medicine, one of the things that I think historians can be helpful in a conversation is when thinking about what historical relationships have looked like that set the stage for what contemporary relationships look like, right? And the medical community has been complicit in the abuse of non-cis straight people for a long time, whether that had to do with chemical castration and the so-called treatment of homosexuality using steroids and hormones, whether that had to do with aiding and abetting the criminalization of homosexuality and the institutionalization of people who were not cis straight people, whether in jails and prisons or in mental institutions. Those are very real experiences that have, I think, informed people's sense of whether doctors and nurses and public health institutions really exist to serve their interests or not. And as we start to think, I think, I know this series is partly at least aimed to students who are seeking careers in the health professions. This is one of the things that you have to think about is what histories do people bring with them that inform their expectations of medical providers, that inform their expectations of institutions. And for LGBTQ plus people, those are not always positive histories. And so that's something else to keep in mind. So I'm actually going to stop there. I don't have any pretty pictures. I apologize. I'm happy to talk. I'm sure, like Professor Kuby, I also have a lot to say about AIDS, and I could go on at length about that. I could also talk a little bit about things in other countries, but I'm curious to hear what other people want to hear more about or want to share with us.
Yeah, there's no formal way to provide your question or thought. You're welcome to unmute yourself, or if you'd like to pose the question in the chat, I'm happy to read it out loud, but let's discuss.
I had one thing I noticed in Dr. Kuby's presentation. I thought it was really interesting that a lot of the pictures, particularly of the protests surrounding AIDS, they were all in black and white, or most were in black and white, and there was color at the time. So is there a reason that it's made to look older than it really is?
That's a really good question, which probably says more about just like the questionable ways that I find images for teaching at the last second, which is probably, honestly, I don't know even where these are all photos that I've used for teaching before, so I truly don't off the top of my head even know. I think that there's also a lot of color documentation. I mean, one thing that's kind of stunning is that in the, oh, sorry, are we seeing a screen being shared with some images in color? Yeah, I mean, I don't know, Alex. I think that it might be more of just a coincidence there than anything else. So I don't want to make too many assumptions, but just to say that there's a lot of footage. I mean, it's one of the luxuries of studying relatively recent history, and that there's a lot. Julia, do you want to
Sorry, I didn't realize I was muted when I was explaining that. Sorry. I mean, my gut is that a lot of, again, what we pull from the internet is reprinted from newspapers. And while color documentation was certainly available in the 1980s and 1990s, color newspaper printing was still pretty unusual. And so I think even though, so a lot of photography was done by journalists for newspapers who were shooting in black and white, or they were scanned in black and white and we've lifted them from the internet. But, you know, I think historians have done some interesting work, like Richard McKay is the one that I'm most familiar with, but you know, people's personal archives have a lot of color photography. And so I think there's really excellent documentation of what Professor Kuby was talking about, the at-home care, some of which is in color, some of which is in black and white. But yeah, it is an extraordinarily well-documented epidemic.
And I was just going to say, before I got confused, that there were like 3 documentaries, the feature film documentaries that got released between, I don't know, like 2014 and 2016. How to Survive a Plague, We Were Here, and one on ACT UP that I think is actually better than the other 2, but I can't remember what it's called off the top of my head. Fighting in Anger. Anyway, the point is that there's just a lot of people's personal records of these meetings and of these protests, and most of that I think is color film. Yeah.
United in Anger, is that the one?
Yes, ACT UP, United in Anger, yeah.
Anyway, I have a question, but I want to give other people a chance to ask questions first.
There was something else. This is what happens when you don't write a PowerPoint. Karen was talking about this earlier. I left something out. I did want to acknowledge that, you know, I think it's important to think about intersectionality, of course. And, you know, a lot of the tension in the history of ACT UP and GMHC has had to do with whether or not people of color were included, whether or not women were included. And, you know, so I think identity is complicated and multi-layered. And, you know, in some ways separating out kind of queer health from health and race creates, to some extent, I think perhaps the impression that these things are not experienced by the same people in the same moments. And of course they are. But that's particularly around AIDS, there's been some really interesting work on sort of how racial identity and sexual identity and gender identity all informed how people experienced this epidemic. And in most cases, sort of, you know, for most people, the layering of those identities made them even at a greater disadvantage with respect to the healthcare system. So the further you got from the straight white male who didn't have AIDS, the worse off you were. But I think it's important to acknowledge that and where that fits in the conversation.
Along those lines, there's one thing that I wanted to say that I didn't say in my presentation, but it's, there's a great book by Jennifer Breyer, I think it's called Infectious Ideas, that really gets at this in meaningful ways. And the example that's in one of the chapters that I like to teach relates to these very community campaigns that I'm talking about that were responses to government inaction, but some of the AIDS prevention campaigns that were springing up in cities like San Francisco, their organizers' objectives were to try to spread safe sex practices, and they targeted gay bathhouses and shops in the Castro, the sort of gay district of San Francisco. What was later pointed out to them by other groups that represented more marginalized communities was that those were typically businesses that were frequented by relatively affluent white cis gay men. So while these programs were very helpful in preventing unsafe sexual practices in those communities, the ways in which they contributed stopped there, particularly because at this point in time, there were disproportionate numbers of white men who are willing, affluent men who are willing to accept the identity category of gay. Many people who often disproportionately coming from working class communities of color, practiced same-sex sexual intercourse without identifying as gay. It wouldn't have ever thought to go to a gay bathhouse in the Castro, wouldn't have ever thought to go to a gay bookstore in an affluent area of San Francisco. So this is one way in which even this sort of community level effort to try to provide care that the government and medical professions weren't providing, it still did not help across the board. And a lot of that relates to oversights and lack of an intersectional framework.
And the challenges of that, as the United States and as particular nonprofits tried to expand models that they perceived to be successful in AIDS prevention outside of the United States, that just exacerbated that, right? I mean, the translating preventive messaging that was aimed at certain kinds of people who identified certain kinds of ways in the United States to places where those categories either didn't have any meaning or didn't have the same meaning, or where homosexuality is or was until very recently still criminalized. It's been a real challenge. And I think, one of the kind of founding myths of scientific medicine is that it's universal. And that is something that, whether you're looking at the history of race in medicine or gender and sexuality in medicine, immediately falls apart. But it is central to the way that many physicians and many public health experts understand what they do. And it's historians, I think, have a lot to say about that.
So we've talked quite a bit about how there was this sort of dropping the ball and there weren't people responding and providing care, specifically in the AIDS epidemic. What, if any, can you share about the people that were offering care, like the medical assistance that was there? How did that come about? Who championed that? And what does that kind of say about healthcare for the community?
I can start. I mean, there's been some really interesting work. I mean, again, because it's relatively recent history, there's been a lot of effort, and because it's like our current moment, I think a moment that people understood at the time it was unfolding as being historically significant. So there's been a lot of work done to document and to publish memoirs of doctors. But there's some interesting cases. So a lot of the doctors that ended up treating AIDS patients in the late 80s and early 90s were actually cancer doctors, were oncologists, because the first diagnosis of many AIDS patients was Kaposi sarcoma. Or they were GPs, or in some cases, they were people that specialized in sexual health. Disproportionately among the doctors that treated early AIDS patients were medical doctors who identified as gay. A lot of doctors refused to treat AIDS patients out of, as Professor Kuby said, a combination of fear of being infected and just the deep stigma around homosexuality. And the other, I mean, the first name that was actually assigned to AIDS wasn't AIDS, it was GRID, it was gay-related immune deficiency. And then later was sort of not professionally, but casually referred to as 4-H syndrome for homosexuals, hemophiliacs, heroin injectors, and Haitians. And so all four stigmatized, well, hemophiliacs, not so much, they were seen as the innocent victims. But the other three groups were highly stigmatized. And so it was a self-selected group. And it's a group that, at least in retrospect, has really defined itself as a group of socially conscious, powerfully motivated by conscience doctors who really saw what they were doing as not only a service to individual patients, but to communities. But I think the other thing AIDS did in many cases was in some ways draw attention to how much the medical system in America relies on family care. And one of the tragedies of the early AIDS epidemic was how many victims were disowned by their families because of stigma around homosexuality. And where I think often even today, it's sometimes invisible. If you know anyone who's seriously ill, then you know how much care is actually provided beyond the medical community, right? Whether even if it's just taking people to their doctor's appointments, cooking for them, making sure that they have the food that they need to eat. And what happened with so many AIDS patients was the people that everybody assumes will do that, just largely mothers and wives and sisters, frankly, they were not present. And so in many cases, the communities that they had formed of friends, of lovers, picked up that slack. But in other cases where people didn't have those support systems, it was really painfully obvious how little the medical care system actually does provide. I'll stop there for now.
The only thing I'll add is that that's why organizations like GMHC's Buddy program became so very vital, because often, I think I kind of flubbed that when I was talking about it, but this was often the only line of interpersonal support and, you know, just conversation that so many people who are suffering from AIDS had. Just having someone who was able to do grocery shopping, to come by, to have a conversation, to help them with basic needs. I mean, yes, it served a lot of physical purposes of caregiving, but I think on an emotional level, it provided a lifeline that many people had lost because of the things Dr. Cummiskey talks about in terms of disownment and the lack of willingness on the part of family of origin to really step up. But yeah, I think that that's why when it comes to discussion of these nonprofit organizations and programs like the Buddy program, I mean, they're serving such a vital need that often I think gets unrecognized.
I don't think you flubbed up at all. You did great. Other questions, other thoughts? We still have a few more minutes.
I'll jump in. We hear a lot about vaccine hesitancy, especially among the African-American community today, and that was a topic of discussion during last semester's series. And there are clear historical reasons for that, and it's not the only community impacted due to the histories that we're discussing. I guess I'm wondering what's the impact for the LGBTQ community, not necessarily in relation specifically to vaccine hesitancy when it comes to COVID, but in general. And so if there were students who are training to become medical professionals, what they ought to have in mind when treating and countering this community in particular. Overall, historically speaking, the maltreatment, the exploitation, and how to engage with that reality, just as you might benefit from being aware of the historical instances that impacted the Black community.
I mean, I can't speak on an institutional level about this. I can speak on a personal level about this. I think that I find that I'm so much more, God, I can't believe I'm going on the record saying this, but I mean, I find that I'm much more nervous about the politics, about the sentiments of healthcare providers. I know, you can see, for instance, mental health care, when a healthcare provider is listed as having a religious affiliation. Is this someone who I want to pursue as a mental health care provider? I don't know, because I think that there are a lot of ways in which various institutions have shown themselves to be extremely homophobic. And I think that when it comes to receiving good care, those are things that I guess it's a luxury to be able to take into consideration, but it also feels very scary not to be able to take into consideration. So that's only a very small response to your question.
Yeah, I think there's a lot here, and I'm not going to cover all of it, nor do I know all of it. I mean, I think that because the story of AIDS, and particularly of ACT UP, is such a formative part of what we think of when we think about queer health, and that was a movement about demanding more healthcare, right? Not avoiding vaccines, not avoiding medication, but actually demanding it, and in fact demanding experimental treatment, right? The right to be experimented upon was largely what a lot of AIDS patients were demanding. That doesn't mean that they trust the healthcare system, right? And I think queer people in general are less likely to have a primary care provider, to have annual medical exams, for exactly the reasons Professor Kuby was saying, that they've had really bad encounters with healthcare providers, or they worry about having bad encounters with healthcare providers. A lot of patients aren't out to their healthcare providers, which can have consequences for what kind of preventive and diagnostic measures are taken, and that can be really complicated. And so, whether you're getting the care that you need is really challenging and will continue to be challenging. The only other part that I would put in at an institutional level is, of course, we live in a country where you pretty much can only get healthcare if you are employed or married to someone who is employed. And, so much of the push for marriage equality was not about wanting to be married as much as wanting to have access to the benefits that are only afforded in this country to married people. And I've totally stolen Professor Kuby's soapbox here, so I'll turn it back over.
I'm happy to not talk about marital privilege for once in my life, so please.
But I think, that is one of the inescapable consequences of living in a country where healthcare is contingent upon employment. That means that anybody who is subject to discrimination in employment is therefore subject to discrimination in healthcare access. And it is still legal to discriminate on the basis of sexuality in any number of arenas of American life. I think including employment in most places. And so that has an indirect effect in terms of who is going to have access to, right now, most vaccination is being offered without respect to insurance, but treatment certainly isn't. And realistically, having the relationships that you need to, for example, find out when and where vaccines are available, that's definitely contingent on certain things.
I just want to, this is tangential, but I think important in terms of providing historical context, that one of the great tragedies of AIDS is that it developed in the wake of gay liberation and sexual liberation. And so much of gay politics in the 1970s was grounded in freedom of sexual expression and the right to be sexual and the right to be proud in celebrating gay sex and gay sexuality. And AIDS did so much work in sort of pushing that back in the closet, in making sex something that was dirty and shameful and a vector of disease. So I don't know exactly how to perfectly tie that in with what Dr. Cummiskey is saying, but I do think it's important to recognize that particular historical timeline from gay liberation to AIDS has had a tremendous impact on how open, particularly individuals of a certain generation are willing to be when it comes to talking about their sexual histories and talking about how sex factors into their medical health.
Can you, is my mic working here? Cool, sorry. New computer and sometimes it craps out and I don't know why yet. Thanks so much for these talks. They're super interesting. And I guess one of the things that I would like to ask is, and I don't know that either of you will have an answer to this, but I'm curious about sort of the contemporary kind of consequences of the patterns that you've been describing. And I'm wondering, maybe about generational divides. So one of the things that I kind of know anecdotally is that the younger generation tend to be more socially liberal, tend to be more accepting, tend to have opinions and ideas, at least as measured by polling, which obviously is imperfect, but that are in a lot of ways a break with even people who are 15 to 20 years older than them. And I guess I'm wondering if either of you have followed these stories into the present and have ideas about what contemporary youth positions toward the LGBT plus community are and how that might change some of these discussions as we move forward.
I don't feel qualified to speak broadly about youth attitudes or generational changes and sort of perception of sexuality. I will comment and say that the medical establishment is an extraordinarily conservative set of institutions. And, I did my PhD in a medical school and had queer friends that were doing actual medical degrees in the medical school. And it was not a supportive environment, shall we say. And so I think there's a lot of still, and medicine is incredibly conservative and incredibly hierarchical. And so I think unlike some institutions, even if a lot of the 21-year-olds starting med school hold different values or perceive things differently than perhaps the people that are 15, 20, 30, 40, 50 years older than them, they have so little power that it's really hard to change the culture. And I think for very practical reasons, choose to expend that power often in other ways, like being allowed to sleep. And so I think medicine is probably going to be the rear guard of a lot of this change, which does not bode well for people's care. I think you see LGBTQ plus people are underrepresented in medical professions because they are weeded out relentlessly. And that's going to be a challenge. So I think, if we are to see this generational change as something that is inevitable, and I don't think that's what you're saying, and I don't think it is, right? But even if it were, I wouldn't expect to see the fruits of that in the medical profession for a while. So yeah, that's what I have to say about that.
I really feel like I'm talking out of, beyond my area of knowledge by drawing too many conclusions, except to say that I'll just say on this institutional level, I often find that, students are the people that I'm the least worried about offending when it comes to talking and teaching about history of sexuality. And I find that a lot of the developments for the better that I've seen at UTC over the 8 years I've been here have sort of started with students airing concerns, and take that for what you will, because this is a small scale example, and I don't know its application to the bigger institutions that we're talking about, but I do think it's something that we all could be cognizant of in how we approach this content. Yeah.
And now, I'm going to go even further away from the things I really know about, but I do think that, I think about, for example, women in medical school and in the medical profession. And it took a long time for women to really be on equal footing. And now they outnumber men in many incoming medical school classes. I think still have lower graduation rates, although that might not be true anymore. But, some of that was facilitated by federal law, right? Relatively powerless people were given avenues to hold powerful institutions accountable. And many of those avenues are not currently available to LGBTQ plus people, right? They do not have the same unambiguous rights in federal courts that women and other protected classes do. And so I do think, I do believe in government, and I think government has a role to play in improving these things that cannot be fully abdicated to, grassroots organizing. That has not worked alone in the past nearly as much as a combination of a grassroots movement, of a movement of youth who have values and, believe in different ways of thinking about things, and the enforcing the police power of the federal government to ensure that powerful institutions respond to them.
Could be like another 2-hour talk on this subject alone. I'm woefully unqualified to say, but I feel like in Tennessee and Georgia, we're seeing a lot of laws that allow these religious freedom laws coming about. And I think that could be a sense that people are more open, people are freer, people are more confident to express who they are and their thoughts. And so a way to keep society the way it is, that we now have to enact laws. And I'm wondering if that's maybe kind of what's happening now. Again, not qualified at all to make these thoughts, but just the things I think in my head. Well, thank you so much. But we are right at time. We've got 2 more minutes. Does anyone else have any thoughts or questions or final things they want to share? Glad that this was very thought-provoking. Well, again, we've recorded this, so it will be up on the Pre-Health YouTube channel in about a week or so. And join us next in 2 weeks on the 18th, where we'll talk about access to care, which we have a fun lineup. And have a lovely evening, folks.